Hello and welcome to my lessons channel. I'm Sriram Jakate. I'm a gastrointestinal and liver pathologist, and these are educational videos. They discuss a specific topic, mainly the clinico-pathological correlative aspect of it. They're not meant for treatment guidance. Let's get started. Well, today's lesson is about how to make a very confident initial diagnosis of celiac disease on the duodenal biopsy. How to be certain that what you're seeing in the duodenal mucosa actually represents celiac disease in a patient. Well, celiac disease is an autoimmune disease that occurs in a genetically predisposed individuals where ingestion of gluten provokes a histological and serological response. And there are a wide range of symptoms. Everything underlined here is of crucial importance. One is there's an autoimmune disease. Secondly, you have to have a genetic predisposition. Thirdly, there has to be gluten ingestion. Without gluten, there is no celiac disease. And the serological as well as the histological response depends a lot on whether or not there is an ongoing gluten ingestion. And the symptoms are very wide ranging. The patient may be completely asymptomatic or have what are known as extraintestinal symptoms or classical gastrointestinal symptoms. Now, celiac disease affects almost 1% of the entire world's population. But sadly, most patients, almost 75% of them, remain undiagnosed in their lifetime for various reasons. And it affects any age. So it's a misconception that it affects younger people. It does have two peaks. One of them is in a very young, 8 to 12 months old, when the children start taking solid food. And their presentation is somewhat different because there is failure to thrive as the main complaint. And then the second peak occurs in adulthood, 40 to 60 years of age, and their presentation is somewhat different. Also, the main histological finding in celiac disease is lymphocytic duodenitis, which means that increased intraepithelial lymphocytes in the duodenum with some component of chronic duodenitis that may or may not have shortened villi. But coupled with that is the positive autoimmune serology that is related to celiac. When you have that combination, you have celiac disease. Let us go through what is lymphocytic duodenitis and how celiac disease may look like, whether there are shortened villi or not so shortened villi. So we start out with a normal duodenum. It has tall villi and it has a few intraepithelial lymphocytes. These are less than maybe 20 per 100 epithelial cells or enterocytes. Now, why not just say 2 out of 10 rather than 20 out of 100? That's because these lymphocytes are not distributed evenly. They are scattered across in clusters. So you have to measure a certain length of the enterocyte epithelium or lining to ensure that the lymphocytes are either elevated or not elevated. And it's best to see a monolayer like this, where you can appreciate the lymphocytes better. Also notice that there are certain numbers of chronic inflammatory cells naturally present or physiologically present in the lamina propria. And pathologists generally have an idea of what is normal cellularity versus what is elevated cellularity. And this is normal duodenum. This, on the other hand, is lymphocytic duodenitis, and it has some slightly shortened villi. And here you have increase in intraepithelial lymphocytes. This is a very busy looking surface, and in the surface, there are these small lymphocytes that are embedded within the epithelium, and they are greater than 30 per 100 enterocytes. Also notice that the cellularity in the lamina propria is elevated as well, and there is also some crypt proliferative activity. There is some mitotic activity in the crypts, showing regenerating crypts. Now this is a further shortening of the villi, but notice that whether or not the villi are shortened, the other changes of increased intraepithelial lymphocytes, increased cellularity in the lamina propria, increased crypt proliferative activity, they are all constant whether or not the villi are shortened. And finally, you have almost a flat surface, and this is severely shortened or severely atrophic villi, again with increase in intraepithelial lymphocytes, increase in cellularity in the lamina propria, and increased crypt proliferative activity. So these are all the changes of lymphocytic duodenitis with or without shortened villi. And some pathologists choose to routinely do a CD3 immunostain that highlights the T lymphocytes, which are the intraepithelial lymphocytes, so that they can easily appreciate how they are elevated. Now, with experience, many pathologists are comfortable with that finding and choose not to do the immunostain, but that is completely up to the pathologist. And along with this very severely shortened villi, you will see some endoscopic changes as well. And this is called scalloping. And these are described in the endoscopic report, where the proximal part of the duodenum will show this parched appearance where there are creases, and this is called scalloping. The degree of lymphocytic duodenitis is graded and originally described by Michael Marsh from England, and this was in late 1990s, and this was later modified in the late 1990s, and it's now called modified Marsh grading system, where there's a type 1 through type 3C, and the lower Marsh grades, the type 1 and type 2, are where the villi are tall, but there is lymphocytic duodenitis with increased intraepithelial lymphocytes, with or without crypt proliferation. And from Marsh type 3 onwards, you have villus atrophy. So 3A is mild villus atrophy, 3B is moderate to marked villus atrophy, and 3C is a complete loss of villi. And keep in mind that celiac patients may have any Marsh grade, type 1 through type 3C. So typically pathologists associate the higher Marsh grades with a greater likelihood that it is celiac disease. And that is true, but that applies to untreated celiac disease in a properly taken duodenal biopsy in a patient who is exposed to gluten in an ongoing fashion. So there are too many variables in that. You can have a lower Marsh grade if the duodenal biopsy is taken from mid-duodenum or distal duodenum rather than the most proximal part of the duodenum. You may have lower Marsh grade if the patient is on gluten-free diet. So there are many other variables. Also, it is important to know that any of the Marsh grades can be seen in disease other than celiac disease. So what are the other diseases that come into differential diagnosis of lymphocytic duodenitis, whether the villi are shortened or not? So we have a long list, and this is not a complete list, but some of the important diseases are other autoimmune diseases, other immune-mediated diseases such as Crohn's, autoimmune hepatitis, SLE, Hashimoto's. Some infections, classically H. pylori gastritis, can typically show increased intraepithelial lymphocytes in the proximal duodenum. Giardiasis rarely does, but it's listed. Tropical sprue and dysbiosis or bacterial overgrowth can actually mimic advanced stages of Marsh grading, uh, just like you see in celiac disease. Lymphomas, Malt lymphoma, diffuse large B-cell lymphoma, or EATL, enteropathy-associated T-cell lymphoma, which is after all a complication of celiac disease. Some drug-induced conditions, NSAIDs, olmesartan, and the higher the grade of Marsh, and if it is properly done in a gluten-exposed patient, it is more and more likely that it is celiac disease and dermatitis herpetiformis, which is, after all, just a cutaneous version of celiac disease. So, with such variation in the extent of lymphocytic duodenitis that you can see in celiac, and the presence of so many other differential diagnoses, how will you then, as a pathologist, be confident about celiac disease in a given duodenal biopsy? So, do you always, as a pathologist, describe the duodenitis and the extent of duodenitis and state that it is not specific and there are other differential diagnoses? That is a fair and factual statement. But in a patient who has clinically a strong suspicion of celiac with the serology being positive, this duodenal biopsy is done mainly to confirm the clinical suspicion of celiac. And such a diagnostic report only creates more workup to exclude other diseases rather than immediately confirm celiac disease. Are you otherwise a pathologist who only raises concern of celiac when there is moderate to severe villus atrophy? And that is fair in a untreated celiac disease. That is typically the case. But as we saw before, we may be missing celiac disease with a lower Marsh grade in certain situations. So one of the ideal ways is to look up the electronic medical record and try to reconcile the histological changes that you see, regardless of the Marsh grade, with the entire clinical picture. And that includes the clinical profile, the gluten exposure, and also the serology. What are the fundamental tenets or pillars of celiac diagnosis? Let's understand that. One is that it's an autoimmune disease. So it has positive serology for celiac-related antibodies. Number two, it has some element of enteropathy where the gluten interacts with the duodenum. And so there is a lymphocytic duodenitis on duodenal biopsy. Number three, it's triggered by gluten. So if you are not taking gluten or you are on a gluten-free diet, all the changes will revert. So with time, with prolonged gluten-free diet, the duodenal biopsies become more and more resolved or normal appearing. And so does the serology. It decreases to borderline to back to normal levels. There is variable and very wide range of symptoms, and we'll describe that shortly. And finally, it is only possible to have celiac disease in a subset of the population who are genetically susceptible and have the HLA haplotypes, which are HLA DQ2 or DQ8. If you do not have them, and 60% of the population do not have these haplotypes, they are excluded from even the possibility of having celiac disease. Let us discuss autoimmune serology in celiac disease. So the commonest antibodies done are IgA antibodies, One is tissue transglutaminase, has 93% sensitivity and 96% specificity. And another one is endomysial antibody, and this has slightly higher specificity than TTG. But both these antibodies require normal IgA levels to be present in the patient and continued gluten exposure or normal gluten consumption. So how many people are actually deficient for IgA physiologically? There are about 1 to 2.5% of the population has IgA deficiency naturally. So these patients, in spite of having celiac disease, may not be able to lodge the antibody response that is detectable in spite of having celiac disease. And when some patients are limiting gluten exposure knowingly or unknowingly, these tests may be falsely negative while the patient really has celiac disease. Now, if you are IgA deficient, you might have to depend on IgG antibodies. And one of them is deamidated gliadin antibody that can be done. And there is a IgG version of TTG antibody that can be done. These are not as sensitive or as specific as the IgA antibodies. What are the best practices in the biopsy procurement for confirmation of lymphocytic duodenitis? So the recommendation is to take 2 biopsy pieces at least from the duodenal bulb. In some patients, the disease is actually quite limited to the bulb, so it's about 10% of patients. And the other recommendation is also include at least 4 biopsy pieces from the most proximal part, which is post-bulb, first part of the duodenum, because these changes would be maximum when there is a full-blown celiac disease. Also, it is important for the patient to be exposed to gluten for the changes to be maximally displayed in the duodenal biopsy. So the patient cannot be on gluten-free diet because then the changes will be lessened as you see them on the biopsy. So the initial proximal duodenal biopsies from untreated celiac will almost always show higher Marsh grade, typically Marsh 3, and may have completely flat lining or severely atrophic villi and scalloped proximal duodenum on endoscopic images. Celiac disease has truly a very wide spectrum of symptoms. In fact, the classical symptoms that people associate with celiac disease, such as diarrhea that is very frothy and fatty, so-called steatoria, weight loss, and malabsorption, the classical intestinal symptoms are present only in about 25% of patients. Another 20% of patients are completely asymptomatic, and the rest have non-classical or extra-intestinal symptoms that may include iron deficiency anemia or megaloblastic anemia, neuropsychiatric disorders, osteoporosis, osteopenia, dermatitis herpetiformis, oral disorders, stomatitis, just the LFT changes of transaminitis, failure to thrive, stunted growth in children, fertility issues. So these are extraintestinal symptoms that are present in a vast majority of patients that may not even raise a suspicion of celiac. That is mainly the reason why many celiac patients remain undiagnosed, mainly for the atypical symptoms and also maybe lack of awareness or lack of resources. About a genetic predisposition to celiac disease, you need either DQ2 or DQ8 HLA haplotypes. And DQ2 is a little more common than DQ8 in celiac patients. And more homozygosity multiplies your risk for having celiac disease. Now, 60% of the population does not have these haplotypes, so they are excluded from celiac disease. Only 30 to 40% population has these haplotypes. But among these, overall, only 1% of people have celiac disease. So there are other genetic factors and environmental factors besides just having these haplotypes. And the genetic testing is done to exclude celiac disease, not to include celiac disease. So if you have a discordant result, for example, you have a Marsh 3C lymphocytic duodenitis, you don't have any other explanation for that, but the patient is seronegative, then if you want to keep pursuing celiac disease as a possibility, then you have to ensure that the patient has DQ2 or DQ8. This is also done in family members of patients who have celiac disease, mainly so that they are not at risk of celiac ever in their lifetime. If they do have these haplotypes, then there is a possibility that they may develop celiac disease in the future if they don't have it currently. So how do you make a confident diagnosis of celiac on the duodenal biopsy? One is by awareness of the full clinical picture, by knowing the symptoms, whether they are typical or atypical, by looking up the endoscopy to see if there is scalloping, and by knowing all the nuances of serology. If there is no serology done, then it is important to recommend serology to your gastroenterologist when you see higher Marsh grades, because that lymphocytic duodenitis may indicate celiac disease that has not been detected clinically before. Now, if you do have lymphocytic duodenitis that is significant in patients who are clearly seronegative for celiac and are negative for HLA, then pursue the differential diagnosis. So hopefully this lesson increases your confidence and your value as a collaborator with your gastroenterology team.